Hit the subscribe button or visit us at auau.auanet.org.
Loss, and the second issue is the issue of bone metastasis. Now, bone loss is relevant because the median age of patients with advanced prostate cancer is consistent with the population at risk for physiologic age-related decline in bone mineral density. This is accelerated by the use of androgen deprivation therapy in these patients, which, as we are aware, is an independent risk factor for osteopenia, osteoporosis, and fracture, as well as the issue of bone metastasis. Why is bone metastasis relevant? Because bone, as we will discuss, is a frequent site of prostate cancer metastasis. Now, when metastases occur to bone, several sequelae may ensue, that of pain for the patient, hypercalcemia, and then what we will group together as what are called skeletal-related events, which are pathologic fracture, spinal cord compression, and the need for either surgical or radiation therapy in order to manage these. In terms of the issue of bone loss, which we'll start with, what are risk factors for bone loss, which we should be thinking about and seeking out in our patient history? Older patient age, previous fracture history, parental fracture history, lifestyle modifications with smoking and alcohol consumption, and then particularly relevant for the prostate cancer patients, use of androgen deprivation therapy and other medical therapies. Now, these are data from an older meta-analysis, or I should say a multivariable analysis from SEER Medicare data that was published in the New England Journal of Medicine, really quantifying the association and even dose dependence of androgen deprivation therapy with fracture risk. Subsequent data correlating the overall survival among patients with prostate cancer who experience a fracture, demonstrating here that patients who experience a skeletal fracture have significantly inferior overall survival compared to patients without a history of fracture. Again, demonstrating the interplay of skeletal-related events and the patient's overall disease course. Now, what should be our approach to bone loss risk assessment for men initiating androgen deprivation therapy? Baseline studies should include a bone density or DEXA scan. This can quantify osteopenia, osteoporosis. Practice dependence, generally, we will get it at baseline and then repeat it every 1 to 2 years while a patient is on androgen deprivation therapy. Baseline blood tests should include calcium, creatinine, and vitamin D. In terms of our AUA guidelines, as far as what do they recommend for bone health in patients with advanced prostate cancer from our update last year, the guidelines advise that clinicians should discuss the risks of osteoporosis associated with androgen deprivation therapy and fracture, recommend preventative treatment with calcium, vitamin D, and then, again, behavioral lifestyle modifications, smoking cessation, regular weight-bearing exercise to patients on androgen deprivation therapy. So initiating androgen deprivation therapy with our guidelines will equal calcium and vitamin D. Calcium, 1,000 to 1,200 milligrams daily. Vitamin D, about 1,000 IUs daily. Again, when we look at our National Osteoporosis Foundation guidelines for men over the age of 50, very consistent with what is recommended for men overall. Data supporting vitamin D, again, meta-analysis here demonstrating significant risk reduction with vitamin D supplementation in patients. Some practical points about calcium. Absorption is better when it is administered in divided doses. The formulation of calcium citrate absorbed better than calcium carbonate. Importantly, calcium supplementation alone does not prevent bone mineral density loss, needs to be done with vitamin D. Now, we will often face questions from patients about data that has been published independently linking calcium with cardiovascular disease, calcium with prostate cancer, and even fatal prostate cancer risk. And again, here, as we talked about in the morning session, is critically important to balance risk stratification. And it is particularly important that we supplement calcium when treating, as we'll talk about, with bone-modifying agents such as zoledronic acid or denosumab. But again, when we think about our AUA guidelines, it is in patients initiating androgen deprivation therapy. Now, in terms of our bone protective agents, such as denosumab or zoledronic acid, again, coming to our AUA guidelines, and I think this is a very important key take-home point. The AUA guidelines outline that clinicians should prescribe bone protective agent, denosumab or zoledronic acid, for patients with metastatic CRPC and bone metastasis in order to prevent skeletal-related events. So that is really a critical take-home point in terms of what is the guideline indication when we are using these medications to prevent skeletal-related events. It is in bone metastatic CRPC. Now, we will talk about a few other scenarios where these agents may be utilized, okay, but when it's for the specific design of preventing skeletal-related events, it's in mCRPC with bone metastasis, and this is likewise for our NCCN recommendations as well. Let's talk about each of these medications. Zoledronic acid is in the bisphosphonate family of medications. It inhibits bone resorption. Now, when it is being used in the setting of bone metastatic CRPC to prevent skeletal-related events, it's once every 4 weeks. This medication is given IV. Now, that dosing interval of every 4 weeks will become relevant when we talk about other situations when zoledronic acid can be used. In fact, it's the only bisphosphonate class that's been demonstrated to decrease skeletal-related events with a benefit in mCRPC. Important to understand the toxicities of zoledronic acid, osteonecrosis of the jaw. We'll talk about these patients should have a baseline dental exam. Hypocalcemia, again, speaking to the importance of calcium supplementation and monitoring of calcium levels. Nephrotoxicity, and we'll have a chart on how to dose adjust if renal function is impaired. And then in acute phase, kind of flu-like reaction symptoms that may occur. This is fever, myalgias, arthralgias, typically occurs in the first 12 to 48 hours, most common during the first treatment. Really, treatment is management for this is conservative. In terms of renal function adjustment, this is just a chart for your reference demonstrating how zoledronic acid should be dose adjusted based on a patient's creatinine clearance and renal function. Now, what about denosumab? Denosumab is a monoclonal antibody against the RANKL ligand. It inhibits osteoclast-mediated bone destruction. This is sub-Q. Remember zoledronic acid IV? Again, though, in the setting of bone metastatic CRPC to prevent skeletal-related events, dosing interval is every 4 weeks. Again, important toxicities overlapping, osteonecrosis of the jaw, get the dental exam, hypocalcemia, supplement calcium. This term osteonecrosis of the jaw, I've mentioned several times, it is basically a non-healing ulcer of the maxillofacial bone in the absence of metastatic disease. It's essentially exposed bone without approximately 6 weeks of healing. Now, what are risk factors for osteonecrosis? Presence of cancer, presence of radiation therapy, but some modifiable ones. Poor dental hygiene, get a baseline dental exam. Active dental work, avoid elective dental procedures, poor fitting dentures, alcohol and tobacco use, as well as I mentioned, bisphosphonate and denosumab treatment. How do we minimize this? Excellent oral hygiene, best prophylaxis, limit alcohol and tobacco use, get a baseline dental assessment and periodic dental assessments during treatment. If possible, have everything done in terms of elective dental work before treatment, avoid in particular extraction, and again, as I mentioned, avoid ill-fitting dentures. What happens though, if osteonecrosis of the jaw develops while a patient is on therapy? Again, this is a risk benefit, but generally the recommendation is to withhold further therapy until the site has healed. Although management is generally conservative with oral rinses, these are patients that we should be thinking about very early on, getting our colleagues in oral maxillofacial surgery engaged, because refractory cases may need surgical debridement. Now, I mentioned that there are two options listed by guidelines, zoledronic acid and denosumab. Is there a preference for use in the patient with bone metastatic CRPC? We actually have a prospective head-to-head randomized trial of these two agents in patients with mCRPC that was published a decade ago now in Lancet, over 1,900 patients. And what the data found here, as you can see from this Kaplan-Meier curve, was that denosumab significantly prolonged time to first skeletal-related event compared to zoledronic acid. There was actually no difference in terms of overall survival with the two agents or time to disease progression. But nevertheless, time to first skeletal-related event longer with denosumab than zoledronic acid. Now, some head-to-head features. What about toxicities? Hypocalcemia, twice as more common with denosumab, 13 versus 6%. Osteonecrosis of the jaw, infrequent with either and not significantly different between the two treatments. Again, zoledronic acid IV, denosumab sub-Q. The acute phase reaction occurs with zoledronic acid, not denosumab. Hypocalcemia, more common with denosumab. Osteonecrosis, rare with both, and neither has a survival benefit. So in general then, because of the longer time to first skeletal event, denosumab is the preferred agent in this setting, although both are listed as options. When we benchmark this against NCCN, very consistent here, M1 CRPC, bone resorptive agent denosumab preferred, or zoledronic acid if bone metastases are present. Now, again, I've emphasized that these are indicated for prevention of skeletal events in patients with bone metastatic CRPC. What about other disease states in prostate cancer? In the setting of castration-sensitive prostate cancer with bone metastasis, in a prospective randomized trial, zoledronic acid did not increase time to first skeletal event versus placebo. And this was published by Matt Smith in JCO, and therefore it is not currently recommended in that setting to prevent skeletal events. What about the M0 CRPC state that we heard about this morning? And again, no overall survival benefit found with denosumab in a randomized trial, not FDA approved in that setting. So again, not recommended to prevent skeletal events in those settings. Nevertheless, although it's not indicated to prevent skeletal events or improve overall survival, what about using these agents to prevent bone loss? Because again, we discussed there's bone loss and there's bone metastasis. We have to be thinking about both in our prostate cancer patients. How do we assess patients' need for bone modifying therapy in the absence of bone metastatic CRPC? There is an online risk calculator known as the FRAX score put out by the WHO. It incorporates the results of the DEXA scan as well as patient clinical features and estimates a patient's risk of hip fracture and osteoporosis-related fracture. And in general, guidelines recommend using bone modifying agents to prevent further bone loss depending on the FRAX score bone fracture risk, as you can see on the slide here. Now, what's the rationale? In this setting, these bone modifying agents are not being used to prevent skeletal events like we were talking about before, but here the concept is to increase bone mineral density and decrease fracture risk. Zoledronic acid and denosumab are two options, but here we also have the option of alendronate. Okay, one thing you can see is the dosing interval, as I mentioned before, is quite different. Before, zoledronic acid and denosumab were each once every 4 weeks. Now, in this setting, zoledronic acid is annually and denosumab is every 6 months. When we look at our AUA guidelines for patients with advanced prostate cancer in terms of bone health in this setting, our guidelines state that clinicians should recommend preventative treatments with bisphosphonates or denosumab to patients at high fracture risk due to bone loss. Again, estimated by the FRAX calculator using the DEXA scan results and patient clinical features. So what do I want to leave you with in conclusion from the first part of this talk about bone health? Bone health is bone loss and bone metastasis. Patients initiating ADT should be offered calcium and vitamin D supplementation. Patients with bone metastatic CRPC should be offered zoledronic acid or denosumab, with denosumab preferred. Beware with either of these of hypocalcemia. Check and supplement calcium. Beware of osteonecrosis of the jaw. Get a baseline dental exam. Patients on ADT should have a baseline and ongoing assessment of their fracture risk, DEXA scan and FRAX. Consider bone modifying agents pending the FRAX score to improve bone mineral density. So with that, let's now move to the second concept we're going to talk about and shift gears a bit and discuss the use of radiopharmaceuticals in advanced prostate cancer. Now, again, as we discussed, the clinical relevance of bone metastasis in the setting of mCRPC patients is that approximately 90% of patients with metastatic CRPC have bone metastasis. We talked a little bit about the sequelae of bone metastasis before: disability to the patients, decreased quality of life, increased cost of care, and decreased survival. Now, prior to 2013, there were really restricted options in this setting. It was strontium and samarium that were primarily used as palliative therapies for patients that were not candidates for other forms of treatment. They're IV agents without a demonstrated survival benefit that were used for symptomatic bone pain. They risk bone marrow suppression because of their mechanism of action. The side effect profile of samarium is slightly more favorable due to its shorter half-life. These agents in prior iterations of the guidelines remained options for symptom palliation under the term radionucleotide therapy, and as recently as the 2015 iteration. Nevertheless, I think these have become dramatically less relevant now with the development of radium-223, also known as alpharidin. This is a structure that is chemically similar to calcium, therefore targets bone to form complexes at areas of increased bone turnover, such as bone metastases. It is an alpha-emitting radiopharmaceutical, which means it has quite a short wavelength. It functions by inducing double-stranded DNA breaks in cancer cells. Because of the short range of alpha radiation, there's really minimal exposure to surrounding tissues, so much less bone marrow suppression, no contact restrictions, for example, to patients being treated with radium. This is an IV infusion given once every 4 weeks for 6 total treatments, can be done in an outpatient setting. Each treatment is quite rapid. It is excreted through the GI tract, so patients can get some GI symptoms during it. Despite the lower bone marrow exposure, nevertheless, lymphocytopenia is the key adverse event here. 20% can get grade 3 to 4 lymphocytopenia, so it's important to check a baseline CBC and then follow blood counts before each treatment is given. This is the phase 3 randomized controlled publication known as the ALSYMCA trial in the New England Journal of Medicine that led to the approval of radium-223 and really led to its establishment as part of our current management paradigm. This trial included over 900 patients with metastatic CRPC and at least 2 symptomatic bone metastases and no visceral mets. Patients were both pre and post-docetaxel therapy, randomized against placebo. Primary endpoint was overall survival. Very interestingly, a bone-directed agent demonstrated significantly prolonged overall survival here. You can see here with radium, median survival was 14.9 versus placebo, 11.3 months, with a hazard ratio of 0.7. In addition to prolonging overall survival, as we would expect based on its mechanism, use of radium-223 also significantly prolonged time to first skeletal-related event, 15.6 versus 9.8 months. When we look at patients both pre and post-docetaxel use, the benefit of radium was maintained in either setting. And when the trial looked at a variety of different sort of biochemical endpoints, alkaline phosphatase, PSA level, radium-223's benefits were maintained across the board. In terms of safety and quality of life, it was very well tolerated. The number of adverse events was actually lower in the radium arm than the placebo arm. There were no clinically meaningful differences in grade 3 to 4 adverse events. And in fact, a significantly greater number of patients had an improvement in their quality of life that was clinically meaningful in the radium versus the placebo arm during therapy. So where does radium now fit into the AUA guidelines recommended management? When we look back at our prior iterations of the guidelines, they said that radium should be used as should be offered, I should say, to patients with good performance status, symptomatic bone metastasis in mCRPC, no visceral disease before or after docetaxel, and may be offered to patients even with poor performance status when the poor performance status was thought to be due to the bone metastasis. The most recent iteration of the guidelines, I think, has made things more simple by stating that clinicians should offer radium-223 to patients with symptoms from bone metastasis from metastatic CRPC with no visceral mets and no lymphadenopathy greater than 3 centimeters. And that is really the take-home point from this second part of the talk. Where do we want to use radium? It's in this setting. Now, again, when we look at our NCCN guidelines, where does radium fit in? Very consistent with what we saw. Of M1 CRPC can be used as a first-line treatment option here for patients with symptomatic bone metastasis, can be used following abiraterone or enzalutamide, as well as following first-line docetaxel therapy, and then again in subsequent therapies for patients with symptomatic bone metastatic CRPC as a category 1 recommendation. Where is this going in the future? There are a number of lines of investigation on radium. One is to try to identify the patients who might be most likely to respond. A few studies have looked at some biochemical parameters. I think going forward, as with multiple areas, molecular biomarker stratification may play a role here, although that's yet to be determined. What about retreatment? I said this was to be given initially as 6 treatments. This is one very small phase 1/2 study that demonstrated that patients could receive a second course of treatment here, that it was safe with a progression-free survival of 9.9 months. How about combination therapy? I think this is a very nice illustrative example of the importance of doing prospective trials to test hypothesis. So initially, radium-223 was looked at in this expanded access, open label, single-armed phase 3b trial, not a prospective randomized study. And what the trial looked at were the results of patients who received concurrent therapies with radium. Because this was not a prospective randomized trial, there was a host of different therapies that were included, as you can see on the slide here: abiraterone, enzalutamide, bisphosphonates. And from this data, which is largely observational type data, essentially an exploratory analysis, it appeared that the safety profile was similar to patients receiving combination therapies, and that, in fact, there may be a benefit, as you can see from the curves here, in terms of overall survival of combination therapy, both with novel endocrine agents such as abiraterone or enzalutamide, as well as denosumab. That type of data then led to appropriately prospective randomized clinical trial testing, which was done in this trial here, the ERA-223 trial, which randomized patients who were receiving abiraterone to receive radium-223 as well or not. This was over 800 patients. Median follow-up was a little under 2 years. The primary endpoint in the trial was symptomatic skeletal event-free survival. And what you can see here is that adding radium-223 to patients receiving abiraterone did not improve symptomatic skeletal event-free survival, but unfortunately, adding radium to patients receiving abiraterone did significantly increase patients' risk of experiencing a fracture. And therefore, because of those data, it is not recommended that radium be used together with abiraterone right now. No benefit in terms of skeletal event-free survival and increased fracture risk. Important to, again, dissect these trials. Only 40% of patients in that trial were on denosumab or bisphosphonate, despite the guideline recommendations that patients with bone metastatic CRP should have been. This is being tested now in a variety of different settings in combination therapy, and I anticipate we will see more and more data rolling out on this in the coming years. So what do I want to leave you with in conclusion about the second part of the talk? Radium-223 is a standard management option for patients with symptomatic bone metastasis in the setting of metastatic CRPC in the absence of visceral mets or lymph nodes greater than 3 centimeters. It can be used before or after docetaxel, well tolerated, improves overall survival. Remember to monitor the CBC. In the future, as we move forward here, it's going to be patient selection, perhaps combination therapy, and then integrating with, as we discussed earlier, novel imaging modalities. So with that, I'm going to stop. And again, thank you very much for the opportunity to be part of the faculty today. With that, I'd like to introduce Dr. Deborah Kay from Duke University, who will be providing our next lecture.